Alwi.
Alwi, okay, alright. So Alwi did macam mana?
Ada 2 orang pesakit dan 2 orang
Okay, what case did you
student
discuss? What case did you discuss?
bronchiolitis and dengue.
Okay, alright, fine, good. Okay, let's begin our session with Kitab. Al-Fatihah. Okay, all right. Before we begin, I always begin the first session with any group of students with almost the same things, because these are things that I think is important, at least for me, and I think this will actually be useful for you as well later on when you are in other postings as well, and also obviously will be important for you, will be useful for you when you are doctors later on. Okay, the thing that I wanted to start with is this session case-based learning and your exam later on, when you see patients, when you're doing your face-to-face sessions, is that you need to clock patients, isn't it? You need to clock patient. You need to get history and physical examination. You need to get history. You need to do physical examination for you to get the proper case to present. And then you will present those cases, isn't it? And you as doctors, as medical students, you'll be presenting cases so many times. And when all of you become doctors, you'll be presenting cases all your life, all your career. You'll be presenting cases. So what is the objective when you clock a patient, when you do physical examination, and when you summarize, when you present the patient as a case presentation? What is the objective? What is the purpose? What are the things that you want to achieve? I've given this to all the groups before. I don't care. I'll be repeating the same thing later on when you're year 5, I'll be repeating the same thing because people always forget. Okay, what are the objectives? There are 4 objectives. Anyone can guess the first objective? Shafiqah was trying to say something just now.
To get professional diagnosis.
Yeah. So the first objective is to get to your provisional diagnosis, to focus, to zoom in on your provisional diagnosis, because you will be managing the patient, you will treat the patient, you will formulate the prognostics, you will do the necessary investigations, the management, the initial management. Everything will depend on your provisional diagnosis. So the history that you got should be clear, should cover everything from head to toe about the provisional diagnosis. You need to get as much history as possible that settles everything about your provisional diagnosis. If your diagnosis is asthma, you need to get everything as detailed as possible about that provisional diagnosis, because that is how you are going to manage the patient. So detail about the provisional diagnosis. Your physical examination as well. It should really point toward your provisional diagnosis. You should make the provisional diagnosis very, very clear. So the first objective, and when you present as well, when you present the case as your case presentation, either as in a man or ski, or in a long case presentation or short case presentation, everything, it should really zoom in. People that listen to your presentation should clearly know, oh, okay, you are trying to sell this diagnosis. So this should be very clear. So the first objective is to sell, is to get your provisional diagnosis. What is the second objective? Second objective. Zulwaka, macam tengah sengih-sengih ni, mesti ada answer.
To rule out out DDX, differential diagnosis.
To rule out differential diagnosis. So that is the second objective. And because as doctors, we are detectives. We are looking, we need to look at the patient as a whole. This is a story that I always tell students. So I've had an incident before when I was in USM when I did my masters. So the managing team, the consultant, the registrar, the MOs, HOs was managing this one patient with this one diagnosis. Again, sometimes when we get the history, we clock the patient initially at 3 a.m., at 4 a.m. So we don't get full detail history. Sometimes the father yang bawa initially, so father sometimes they don't know a bit detail, so needs the mother. So sometimes the first diagnosis wasn't really clear. But the thing is, the whole managing team were managing this patient as this particular diagnosis. So then comes this medical student who presented the case as a case presentation. So this medical student, being a good medical student, got very detailed, very thorough history, good differential diagnosis. So because this presentation was so good, it points toward a different diagnosis. So how, and then the whole managing team changed their diagnosis, and change the management of the patient. And they have actually saved the patient. Who actually saved the patient? That particular medical student, because the history is very thorough, very robust, not just narrow, just point towards only one provisional diagnosis, but have good differential diagnosis. So having good differential diagnosis is extremely important, because again, another issue is an-nasu khatta'un. Kullu ibni Adam khata' wa khairu khata'in at-tawwabun. Human make mistakes. This is the Prophet said. To be human is to make mistake. It's usual, it's common. To be human is to make mistake. And as doctors, we need to allow that we need to allow the space that human make mistakes. People may not get detailed, full history, and it is our job as a good doctor for us to actually get a thorough history. We need to always think, is there something else that someone have missed before? Is there something else that I have missed before? So each time we review the patient, we need to think, what are other things that we have missed? And we will never know the things that we have missed unless we have good differential diagnosis. I've had one student before. I think it was a year 5 student, I think in the exam a few years back. So, you know, we don't have that many patients with bronchiectasis. Obviously in HTA, in SUSMEC, actually we have one patient. But in HTA also we have 1 or 2 patients only with bronchiectasis. So there was this one block exam where I had this one student who got this patient with bronchiectasis. And again, as I said, we don't have that many patients with bronchiectasis, only 1 or 2 patients with bronchiectasis. So this particular student has actually presented this particular case for long case presentation. So when dia dah present this case for long case presentation, dia dapat pula this case for block exam. So what happened? Dia assume dia dah tahu diagnosis is bronchiectasis. So the presentation is narrow, bronchiectasis je. Dia tak fikir what are the other differentials for bronchiectasis. What are the causes for bronchiectasis? Dia tak fikir dah. Dia narrow sebab dia assume dia dah tahu that diagnosis. That's a problem, kan? And then pula bila dia dah tahu this diagnosis, dia dah pernah clerk this patient, dia assume dia still remember all the details about the patient. So dia pun tak clerk in detail. Dia tak do detail full physical examination. Mother pula remember, oh, I have already told this student the story about my daughter, about my son. So mother pun tak cerita detail pada dia sebab I assume dia dah bagi tahu. Kan? So the problem, what happened to that particular medical student who had exam with me was the history, the physical examination was very narrow, was shoddy, tak detail, kan? Only focus on one diagnosis, no differential diagnosis at all. And obviously that student failed. There's no chance you're going to pass because your history is too narrow. Because as medical student, as doctors, you need to always think, what are the other differential diagnoses? What are the other things that we have actually missed? Again, you can only ask good questions. You can only ask good questions if you know the provisional and the differential. When you don't know the differential, how can you ask question? You can only ask generic question. Sakit apa? Kenapa? Ada apa? That's generic. Kan? But sometimes you cannot get detailed history without knowing the details. So you can only ask the details. You can only do checklist of the problems when you know the differential diagnosis. You can only ask appropriate questions when you know differential diagnosis. You can only do proper physical examination when you know the differential diagnosis. Sebab itu, having good differential diagnosis is very, 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 very superly important. Kan? And for year 3, I expect you to have at least 5 differential diagnosis. So 1 provisional and at least 5 differential diagnosis. Bila you year 5 nanti, I expect at least 7 differential diagnosis. So think, what are the differential diagnosis? Ask the questions. So in your clerking, in your physical examination, when you present the case, you need to have all the positives and all the negatives of all the 5 differential diagnosis. Orang yang dengar your presentation, bila dia dengar your presentation, dia should boleh tahu dah, okay, this is the provisional that you are trying to show us, and these are the differential that you are trying to rule out. Orang dengar tu boleh tahu dah, okay, this is the differential because of this, and this is not the diagnosis because this and this and this. So orang yang dengar tu boleh tahu dah. So bila you clerk patient, you need to think this way. When you formulate your presentation, you need to think this way. Have I actually ruled out adequate differential diagnosis? Have I got enough information from history and physical examination to rule out at least 5 differential diagnoses? Or I don't have any idea. Faham? You need to think. Okay, those are 2 different two objectives. What is the third objective? Third objective.
To know the complication and the severity.
To look for complications of the disease. Because all disease, severity akan masuk under provisional. Severity will be part of the provisional, because provisional diagnosis, you kena tahu detail about provisional diagnosis. And so the third objective is to look for complications of the disease. Because all disease, everything has its own complication. Nothing in this world tak ada complication. Asma ada complication. Allergic rhinitis ada complication. Kan? Diabetes ada complication. Thalassemia ada complication. So everything ada complication, and it is your job from your clerking. You need to look for what are the possible complications of the disease that you are talking about. You need to do physical examination to look for the potential complications of that disease. And when you present as well, your presentation should actually explicitly try to look for the complications of the disease, because this is our job. This is our job, and this is what I expect from you as medical students. What is the fourth objective? Fourth objective. Anyone? Tuan Fadil, dia pernah duduk sengih-sengih dia. Mesti ada idea bernas.
To give the treatment.
You start treatment based on your provisional analysis. So the fourth objective is to look for complications of treatment, to look for complications of management, because whatever you do to the patient has its own complication. Kan? Minum air kosong pun ada complication. You bagi nap ada complication. Kan? You bagi paracetamol ada complication. You pasang IV line ada complication. You ambil darah ada complication. Whatever you give to the patient, whatever treatment you give to the patient has its own complication. Whatever mother gives at home ada complication. So whatever management that you do to the patient has its own complication. And not just that, whatever you didn't do as well ada complication. So doing things ada complication and not doing things ada complication. For example, if you have a patient with febrile seizure, for example, febrile seizure, kan? Patient ada febrile seizure. Do you think mother will do nothing at home? Nampak anak seizure, mak dia pun tengok je, oh seizure, bagus. Do you think mother will just do like that? No, isn't it? Mother will do something. Kan? Tak ada mother tengok je sambung tengok Netflix. Tak ada kan? Mother will definitely do something. Muhammad, sikit. Kan? Mother will definitely do something. And that something that the mother does has its own complication. Some mother actually panic. Dia panic tak tahu nak buat apa. Kan? Not doing anything pun ada complication. So what are the complication when you have seizure and you don't do anything? There are complications of it. Kan? I hope you know lah. I'm not going to talk about that. Kita akan talk about that nanti bila face to face nanti. I hope you know lah. Kalau tak tahu, you make sure you know before your exam. If your clinical exam nanti ya. At least before your professional exam nanti kena tahu lah. Kalau tak juga, at least sebelum jadi doktor kena tahu complication ni. Kalau tak, you better delay being a doctor dulu. So you need to know the complication of not doing things. Kan? And remember, sometimes when you see patient, contohnya you clerk patient, kan? Before being admitted, kan? Probably dia dah being unwell for 3 or 4 days before admission. Do you think 3 or 4 days being unwell, mother akan tak buat apa-apa? Definitely the mother will do something, kan? And that anything that the mother does has its own complication. Do you think 3 to 4 days before being admitted, ada tak possibility mother dah bawa seek treatment dekat GP ke apa? Kan? Probably. Kan? Kalau the patient has been unwell, people don't usually bring straight to hospital. Dia bawa pergi klinik dulu. Kan? And obviously clinics, they must have done something. Kan? Dia mesti buat something. Dia tak akan ignore je. Okay, biar je. Kan? Dia mesti buat something. So that something may have complication as well. Kan? Itu kalau mujur dia bawa pergi ke GP. Kalau dia bawa pergi jumpa Tok Bomoh ke, kan? Jumpa siapa-siapa kan. So mana kita tahu? And everything has its own complication. For example, recently we have one patient with relapsed nephrotic syndrome. No, bukan relapse lah. Basically spontaneous bacterial peritonitis in our ward. Kan? Datang dengan dia focal segmental glomerulosclerosis, FSGS, steroid resistant nephrotic syndrome. Kan? Datang dengan spontaneous bacterial peritonitis. Kan? Tengok creatinine dia extremely high, more than 100. Rupanya for the past 1 week they have been taking this supplement yang dia beli kat luar, dia beli ubat jamu-jamu, kononnya ada habatus sauda, ada apa semua benda lah, but we don't know what is actually the real concoction, and we think because of that lah dia punya creatinine dia elevated. So the thing is, what I'm trying to say is, whatever the parent do and whatever the other people do, datuk ke siapa bagi ubat apa-apa benda, and all this can cause complication. And not just that, the thing is, before being admitted in the ward, before you clerk the patient, dekat ED, patient dia bukan datang straight daripada datang hospital terus masuk ward. Dia pergi emergency department dulu, ED. And in ED also, some treatment may have been done. Dia pergi ED, takkan ED buat je, kan? ED mesti buat something kan? Kan? So that something has its own complication. How to know? Sometimes you boleh tanya. Contohnya dekat ED tu berapa lama dekat kecemasan? Apa dia buat kat kecemasan? Because sometimes you probably have clerked the patient day 5 of admission, for example. Tapi probably masa patient sampai dekat ED in comatose condition. Kan? In severe asthma condition, for example. Kan? Intubated ke apa, non-invasive ventilation ke, in shock ke, pasang line sampai 3-4 kan. So if patient stay lama, needed resuscitation in ED, so you know the patient comes in a very bad condition, in a severe condition. So knowing what happened in ED is important as well. Kan? You kalau patient datang dengan asma, masa you clerk dah day 5, probably asma dia dah clear dah, tak ada rongkai dah. Tapi probably masa dia datang tu in status asthmaticus, started on IV magnesium sulfate infusion. Kan? So knowing what happened masa dekat emergency department is actually important for your presentation. So look for the complications of the treatment. And again, if you clerk the patient several days after admission, definitely someone has done something masa admission. Takkan buat masa admit tak buat apa-apa. Definitely kita dah buat something. And that whatever thing that we do may have complication. Kan? Contohnya orang asmatik. Kan? Orang asmatik you bagi nebulization. What are the problem with nebulization? Apa complications of nebulization? I know year 3 we have not discussed too much about management, but you need to know some of the things. Because I'm not asking you about management, I'm asking you about the complication of things. What are the complications of nebulization of salbutamol, beta agonist?
Tachycardia.
Tachycardia, yes. Lagi?
Tremor.
Tremor, yes. Lagi?
Palpitation.
Palpitation, yes. Lagi?
Arrhythmia.
Arrhythmia, yes. Lagi? Satu lagi. If you take blood, what can you see?
Hypertension. Increased blood pressure. No.
Hypokalemia.
Hypokalemia, yes. Hypokalemia. How salbutamol causes hypokalemia? How salbutamol causes hypokalemia? Akil jawab tadi kan? Macam mana? Akil Akram. Macam mana? Hi. So potassium is an intracellular solute. If you compare sodium and potassium, for example, sodium is mainly intravascular. Potassium is mainly intracellular. So what happens is salbutamol causes shift of potassium through the sodium potassium channel. From intravascular, it goes more into the intracellular. It shifts potassium to go into the cells, into the intracellular space. So this is what salbutamol does. Okay, so what I'm trying to say is, when you clerk patient, you need to get all this history. So provisional diagnosis, your history, your physical examination, and when you present the case, it should highlight, it should it should focus, it should zoom in on your provisional diagnosis. It needs to rule out at least 5 differential diagnoses, all the important positives and all the important negatives for you to rule out 5 differential diagnoses. You need to look for all the complications of the disease, and you need to look for all the complications of all the management at home and during admission and throughout admission. So these are the 4 objectives that you need to cover. You need to cater. You need to be thorough in your history, your physical examination, and your presentation. Okay, clear. The other thing, when you do provisional diagnosis, this is something that you will always do. Again, if in MEN or SKI, for example, we'll ask you to examine the patient, and then we ask you to present your finding as in short case, and then we'll ask you what's the diagnosis. So diagnosis is basically your provisional diagnosis. So I give you one example. If you have a patient presenting with asthma, because you've discussed already with Dr. Alwi about bronchiolitis. Okay, for example, if you have a patient where you think the diagnosis is asthma, how would you formulate the provisional diagnosis, the diagnosis tu? Macam mana, how would you say the full diagnosis? Macam mana? Siapa ada idea? Soalan tak berapa clear.
If it is acute exacerbation or the patient come for follow up? I mean like the cost of coming to the hospital.
Okay, so that's good. So kalau patient datang in exacerbation, you need to tell the patient comes in exacerbation. So maknanya your diagnosis should be acute exacerbation of bronchial asthma. But that is not enough because you need to show the severity of the acute exacerbation. For example, macam how do you classify as exacerbation, severity of exacerbation? Macam mana? Siapa ada idea?
Mild, moderate, severe, and life-threatening.
So mild, moderate, severe and life-threatening acute exacerbation of bronchial asthma. Mana nak tengok benda ni?
Fits protocol.
Yeah, so that's the minimum reading for year 3, year 5 student, medical student. The minimum reading for pediatric posting is the Malaysian pediatric protocol from Malaysian Hospital 4th edition. Yang color purple tu. So that's the minimum baseline reading. Kan? Lepas tu you nak baca buku Tom Lissauer yang sunflower tu pun boleh lah. Suka hati lah nak baca buku tu. Kan? You nak baca Nelson pun tak apalah, suka hati. Okay, bagus lah you nak baca Nelson. But at least the minimum reading is PITS protocol. Kan dalam PITS protocol tu ada how you classify asthma severity. Severity of asthma exacerbation. Kan? So mild, moderate, severe life-threatening acute exacerbation of bronchial asthma, and that is still not enough. Kenapa not enough? Sebab exacerbation tu ada dia punya trigger. There must be a cause. There must be a reason. There must be something yang causes the exacerbation. So you can kata mild, moderate, severe atau life-threatening acute exacerbation of bronchial asthma. Secondary to apa? Secondary to URTI, secondary to pharyngitis, secondary to tonsillitis, secondary to pneumonia, secondary to cold weather, secondary to cold drink, secondary to house dust mite, secondary to jerebu. So whatever the reason, you kena bagi tahu lah, ataupun secondary to unknown cause. So tak kisahlah, but you need to tell us what is the reason for the exacerbation, because you need to treat that. So provisional diagnosis must be full. So mild, moderate, severe, life-threatening, acute exacerbation of bronchial asthma, secondary to apa reason dia. Is that enough? That is still not enough. Apa lagi yang nak kena ada? Apa lagi nak kena ada? For full diagnosis.
Know if the patient is on treatment.
So status of the asthma. Status of the asthma. Status of the asthma, how do you classify status of the asthma? You will classify according to whether the patient is newly diagnosed ataupun already known asthmatic. Kalau patient yang newly diagnosed bronchial asthma, can you classify according to intermittent or persistent? Persistent pula ada mild, moderate, severe. Itu kalau newly diagnosed. Kalau patient yang known bronchial asthma or already on controller medication, so you classify according to control, partly control or poorly control. Faham? So kalau you have patient yang asthma, the diagnosis will be a mild, moderate, severe, life-threatening acute exacerbation of bronchial asthma. Secondary to apa cause dia punya trigger for the asthma exacerbation, with underlying newly diagnosed intermittent or mild, moderate, severe, persistent bronchial asthma, ataupun with underlying well controlled, partly controlled, poorly controlled bronchial asthma. So this is how you make the diagnosis. Sama juga dengan patient yang datang bukan sebab exacerbation. Contohnya you datang for follow up, ataupun patient tu datang for your exam. So the diagnosis pun sama lah. Diagnosis tak payahlah ada exacerbation. So my diagnosis is bronchial asthma. Diagnosis dia sama, you kena bagilah. So underline apa? Newly diagnosed intermittent bronchial asthma, ataupun kata control bronchial asthma. Control, partly control or poorly control. Faham? So the diagnosis kena full diagnosis. Sama juga if the patient has other problem. For example, febrile seizure. You tak boleh kata bila I kata diagnosis, what is your diagnosis? You kata my diagnosis is febrile seizure. That is not enough. Sebab febrile seizure ada cara kita nak classify dia. How do we categorize febrile seizure? Macam mana? Farah Anis, tak dengar suara lagi daripada tadi. How do you classify febrile seizure? Macam mana? Tak payah Google. Macam mana? How do you classify febrile seizure?
Based on the severity.
Huh?
Based on the severity.
Severity. Aiman? Macam mana?
Duration and onset, either recurrent or not.
Faiza Nur Rafika. Macam mana?
Simple or complex.
Macam betul dah. Tak apa dengar. Macam kuat sikit.
Simple seizure or complex seizure.
Betul. Yes. So febrile seizure, you classify whether the simple or complex febrile seizure. So diagnosis, you tak boleh kata febrile seizure macam tu je. You kena bagi simple febrile seizure ataupun complex febrile seizure. I hope you know lah how to differentiate between simple and complex febrile seizure. Again, dalam PIP protocol ada mention pasal ni. Kan? I hope you know the how do we diagnose febrile seizure. Dia ada dia punya kriteria for how you diagnose febrile seizure. Kan? But how you classify dia simple or complex febrile seizure. Kan? Is that enough? Apa diagnosis? My diagnosis is simple febrile seizure. Is that enough? Tuan Fadil was trying to say something. Huh? No, you're not trying to say something. That's not enough lah. So kenapa not enough? Sebab febrile seizure, dia mesti ada cause dia for the seizure. Faham? Febrile seizure is a complication of having fever. When the child has fever, the child will get seizure. That is febrile seizure. Kan? So dia mesti ada reason for the fever. So maknanya, the diagnosis should be simple or complex febrile seizure, secondary to something. Secondary to apa? Secondary to pharyngitis, secondary to tonsillitis, tonsillopharyngitis. Secondary to apa? Secondary to pneumonia, secondary to AGE. So whatever febrile illness can cause the child to have febrile seizure. So your diagnosis should have the cause for the fever. So that is how you formulate your diagnosis. Why this is important? Again, because when you make provisional diagnosis, that provisional diagnosis should be complete and thorough. Why? Because this is how you manage. When you have a patient with febrile seizure, you don't only treat the seizure, you treat the cause for the fever as well. When you have a patient with asthma, you don't only treat the exacerbation, you treat the underlying cause as well. You treat the cause for the exacerbation. You treat the underlying status of the asthma. If intermittent asthma, treatment macam lain. If persistent asthma, management macam lain. If control asthma, management macam lain. If partly control macam lain. Poorly control macam lain. So when you have proper full provisional diagnosis, then can only you properly manage the patient. Okay. Clear so far? Boleh? Fahim Tum Kalami?
Fahim.
Baik. Okay. Alright. So that's the mukaddimah for the session with me. Alright. Okay, what we'll do next is, okay, I'll give you one scenario. And then let's see how what are the other. Okay, we go one by one. I give you one scenario, and then one by one you tell me what do you think, what are the other history and physical examination that you would want to know. Okay, all right. Okay, so I'll tell you I have a patient. let's say 3 years old Malay girl presented with periorbital puffiness. Okay, so 3 years old girl, periorbital puffiness. So what are the other history and physical examination that you would want to know? Okay, we'll go according to the list in my screen here. We'll begin with Tuan Fadil, followed by Zulwakar, and then Akil Akram, then Faiza Nur Rafika, Nur Syafiqah, Aiman, Farah Anis, Ainul Hayati, and then Nurul Hannan. Okay, all right, clear. Again, Tuan Fadil, Zulwakar, Akil, Faiza, Nur Syafiqah, Aiman, Farah Anis, Ainul, then Nurul Hannan. Okay, all right. So let's begin. Tuan Fadil, information.
What do I want to ask? Okay. Is there any allergy?
Cuba tanya dia dulu sikit. So no, I'm not asking how you would ask, but what do you want to know? History of allergy, what? What are you trying to test? What are you trying to get?
Wait, wait. I'm not sure.
What are you trying to get?
Can I make Talia Hayat?
Tak boleh. No, you, so my question to you is, what are you trying to get? That is a very important question. That's true. Cuma apa yang you try nak dapat? Are you trying to ask whether there's any history of allergy to anything, or any maknanya dia bengkak tu lepas dia makan something ke apa benda ke? So where are you trying to go?
Mungkin ada makan something. Contoh.
Right, jujur, tapi sebab tak jumpa patient lagi kan. Susah ni soalan ni. Kan? Your question, I assume I get what you're trying to highlight. Tapi cara you bawa that point tu, it tells me that when you ask patient nanti, you won't get that information. Okay, fine. Alright, so for this patient, there's no known allergy before. And there's no history of eating something that causes this swelling. Okay, all right, Zulwakar.
Okay. I would like to ask regarding the the puffiness, the swelling. Is there any other side of the organs such as limbs that become swelling? Is there any sides such as hands or legs that become swelling?
Okay, so the question will be, is there any other swelling elsewhere as well? Kan?
Yes.
Okay, so the mother did notice the abdomen, the tummy is a bit distended, and the leg as well is a bit more distended than before. Okay. All right, Akil.
Doctor,
Yes.
can I ask the mother in Malay?
Tak kisahlah, suka hati. But what I'm trying to get, I'm not asking you to ask question to me. I'm asking you, what are the things that you would want to know?
Puan, anak puan ni dah bengkak berapa lama ya?
Okay, so you want to know the duration of the swelling. Okay, so is that just duration or atau benda apa lagi yang you nak tahu? Is it just duration or is there anything else that you would want to know?
First time ke dah jadi macam ni?
Okay. again, the problem is you have good idea, but you don't focus on that idea. Faham tak? Lepas tu you flip ke tempat lain. So that's the problem. Okay, you ask the duration. What comes with duration is onset. What comes with duration is onset. Okay, when you ask duration, you should always ask onset as well. Yeah. Sorry. Hospital call. Banyak pula benda ni. Ada 3 pula isu. Okay, alright. Fine. Where were we? Apa kita tengah discuss apa tadi? Okay.
Duration.
Okay. So focus. So when you talk about duration, you need to always ask about onset. So obviously you need to ask berapa hari dah dia bengkak ni. But you need to know as well, bengkak ni, okay, dia datang 3 hari, tapi is it sudden onset ataupun gradual worsening by day, kan? Dan dia kena tanya juga dia start tu daripada mana, onset tu daripada mana. Is it start from periorbital or start from abdomen dulu ke ataupun pida edema dulu. So duration always comes with onset. Bukan setakat tu saja, you kena ask juga bila duration ni, you kena tanya ke kalau contohnya dia bengkak ni for the past 3 days. You kena tanya juga the variation by day, throughout the day punya variation. Dia day 1 dikurang, day 3 tu dia makin teruk. Ataupun setiap hari tu dia worsen masa pagi, kurang masa petang. Ataupun macam mana? Dia bangun pagi lebih pada muka, kurang dekat kaki, terus petang tu dia bila hala ke petang muka dah kurang, kaki yang lebih. So then you know ada element of gravity dependence. Kan? So duration is important. Duration always comes with onset and comes with variation throughout the day. Kan? Okay. Faham? Okay. Alright. Faiza.
I would like to ask if the swelling was preceded by any fever.
Fever. There's no onset of fever before. What are you trying to ask actually? What are you trying to get?
Infection.
It might be secondary to infection, such as in the case of post-streptococcal glomerulonephritis.
Okay, in that sense, soalan tu you kena tukar sikit. Sebabnya macam ni. Post-streptococcus glomerulonephritis, most of the times, fever tu datang 1 week before. Maknanya dia ada fever, ada some URTI, fever tu dah settle for 1 week and then baru datang this glomerulonephritis. But we do have, maknanya the first few days tu dia ada fever dulu, lepas tu terus dapat glomerulonephritis. Tapi generally dia datang fever tu is 1 week prior. So bila 1 week prior, kan, fever punya history tu doesn't come with this current punya problem. Fever tu datang earlier. Faham? So you kena tanya instead of just dia mula demam dulu ke? You tak boleh tanya macam tu je. You kena tanya, okay, basically you need to ask the wellness before the onset of the problem. Maknanya is the patient well before? Kan? Bila dia last being unwell? Faham tak? Dapat? Because sometimes you need to panjangkan sikit soalan pasal fever tu. Okay, alright. Nur Syafiqah.
I would like to ask about the urination, the frequency, and also if there's any frothy urine or hematuria.
Macam menarik soalan tu. Semula apa lagi tadi? Banyak pula. Apa? Syafiqah. Again, what
I want to know the urine frequency and output.
Macam mana you nak tanya tu?
She is 3 years old, right? So maybe we can ask the mother how many times the mother changed her diapers, and also how much for each time, how much does she wet the diapers?
Okay, so the thing is macam ni. Changing of diapers ni dia a bit relative. I'm not asking you, I'm not saying it's wrong. Well, you do need to ask the frequency of changing diaper. Tapi sometimes frequency of changing diaper doesn't actually mean, sometimes it doesn't really quantify the volume of the urine. Sebab some others, dia akan change diaper tu, dia tunggu dah penuh baru dia change. Faham? Dia tunggu dah penuh baru change. So sometimes it doesn't really reflect the volume. So maknanya, well, yes, you do need to ask berapa kali tukar diapers dia, ada kurang tak tukar diapers dia, nampak diapers dia lebih kering daripada biasa ke, ataupun lagi banyak daripada biasa ke. So you do need to ask that. Cuma sometimes you kena pelbagaikan your question. You kena pelbagaikan. But yes, this question is very important to ask about whether there's any oliguria or not, reduced urine output, and whether there's any frothy or blood in the urine, proteinuria or hematuria. So any frothy urine or blood in the urine. Yes, Aiman.
I would like to ask about any associated symptom like abdominal pain, to know whether the patient has ascites or peritonitis.
Okay, there's no abdominal pain. Yep. Lagi Farah Anis.
I would like to ask about shortness of breath. Maybe if the patient experience shortness of breath.
Why?
For pulmonary edema.
Pulmonary edema. What diagnosis are you thinking?
I'm actually thinking about the heart also. Heart failure.
You are thinking of heart failure as well. Okay, good. Yep. Okay, good. Alright. Apa lagi diagnosis of the heart failure? Okay lah, tak apa. Fine. Nurul Hanan. Cepat. Apa lagi question? Banyak lagi benda nak tanya ni. Okay, wait. Ainul Hayati, we'll get back to you. Nurul Hanan.
About the periorbital edema, is it come with pain and any discharge like yes.
What are you thinking? What is your diagnosis? What is the diagnosis that you're thinking?
If it comes with discharge, maybe it can be related to like conjunctivitis or allergic reaction and also infection.
Periorbital cellulitis, preseptal cellulitis. So those are more diagnosis for your question lah. Okay, alright. Nurul Hanan, yes. Something that has been bothering me. Aiman, you attend kat mana ni? Bukan kat rumah You kat mana ni?
Saya kat library.
Bagus. Nurul Hanan, yes.
If the patient have any diarrhea.
Why? What are you thinking?
Why?
All right. Any other question? Any other things from the group? Any other things that you think you should know for this sort of problem?
Travel history to like such as dengue endemic area, because dengue also can present with periorbital edema.
Okay, all right. Lagi? Lain? All right.
Oh, maybe we can ask about respiratory.
Huh?
About something related to the respiratory system, such as shortness of breath.
Soalan Zobra Farah Anis tanya tadi.
Hmm. Oh, okay.
Lain? Lain? Okay, let me ask you. As of now, from the histories that you have asked, what do you think is the provisional and differential diagnosis? Tuan Fadil, from what, from the information that you have gotten, the question that you all have asked me, and some of the items that I have told you, what do you think is the provisional and differential diagnosis? Cepat. Cepat.
Wait. Tak ada.
Tuan Fadil.
Wait. Nephrotic syndrome.
Okay, nephrotic syndrome. Yep. Differential.
Differential. Dia tak ada fever kan? Kalau dia tak ada fever.
Differential.
Nephrotic dah. Cellulitis.
Zolwakar. Provisional differential.
Other the professional diagnosis, I agree with Fadil. It might be due to nephrotic syndrome.
Differential.
For differential, I'll suggest acute glomerulonephritis, heart failure, acute kidney injury,
Lagi? Baru dua.
Chronic liver disease, cellulitis, periorbital cellulitis.
Okay, Akil. Provisional differential.
For provisional diagnosis is nephrotic syndrome, because the patient have a periorbital edema and also edema at the abdominal edema and also pedal edema. For my differential diagnosis is acute glomerulonephritis because of the edema too, but they have no history of fever. Next is about chronic liver disease, but the history, our history taking is not sufficient, like not ask about is there any jaundice or not. And next is heart failure, because the edema too, but they have no associated symptoms such as shortness of breath. Next is my differential diagnosis is allergic, but just the mother said his daughter have no allergy, and last is
Okay.
Periobatan cellulitis.
Okay. Faiza.
My provisional diagnosis would be nephrotic syndrome. And as for the differential, acute glomerulonephritis, heart failure, acute kidney injury, liver disease,
Lagi.
IgA nephropathy.
Okay. Okay. Fine. Macam ni. Bila you fikir diagnosis, bila you nak bagi differential, again, you perasan tak? What's the problem bila you all nak ask question? Kenapa susah nak dapat question? Sebab bila you ask, when you were all trying to ask me question, your provisional diagnosis is not really clear. Macam mana nak clear provisional diagnosis bila you don't know the differential diagnosis? Bila you tak tahu differential diagnosis, nak tanya apa pun tak tahu. Betul tak? Macam ni nak tanya soalan kalau you tak ada differential diagnosis. You don't know what are the complications of the disease. Nephrotic syndrome, if your provisional diagnosis is nephrotic syndrome, ada banyak complication yang boleh jadi dengan nephrotic syndrome ni. Kan? So, have you asked appropriate questions tak untuk make sure that you have looked for the complication of nephrotic syndrome? Because nephrotic syndrome, you can go into shock. Nephrotic syndrome can go into pleural effusion. Nephrotic syndrome can go into ascites. All this has complication. Kan? Nephrotic syndrome can even go for overload punya features. Boleh jadi pulmonary edema pun boleh jadi. Kan? And all the differential diagnosis yang you all bagi ni, semua ada dia punya complications. So without knowing clearly what is the differential diagnosis, you will never ask appropriate questions. Kan? So again, I've told you before, that is why I always start my session to remind you what are the 4 objectives. Because you should ask your questions to me should cover all the 4 objectives. Faham tak? Clear tak? Dapat tak? Faham tak? Okay. Next thing. This already 1 hour. Usually I don't do online classes more than 1 hour because I think online classes ni penat. Penat kan? Now, kan? Especially the way I do things. I know it's a bit stressful to the mind. Your mind and my mind as well. And a bit stressful on the emotions juga. It's okay. So I don't usually do longer than 1 hour. Okay, all right. But we're gonna drag it a tiny bit. Nur Syafiqah, enlighten us. What is enlighten us on the pathophysiology of nephrotic syndrome. If you get me for exam and your patient is nephrotic syndrome, I will definitely ask you about pathophysiology.
Okay, so basically the pathophysiology for nephrotic syndrome, it is divided into 2, which is one is the role of podocyte and the second one is the role of immune system. So as we know that most of the time, nephrotic syndrome is idiopathic nephrotic syndrome. So when there is injury to normal epithelial podocytes and also glomerular basement membrane, there will be extensive podocyte effacement. And this will then lead to increased glomerular permeability and causing massive proteinuria and also resulting in decreased serum albumin level. And also when there is hypoalbuminemia, there is this decrease in plasma oncotic pressure, thus resulting in reduction in effective circulating blood volume and also activation of the RAS system. And also when there is activation of RAS system, there's sodium retention and also causing shifting of fluid from the intravascular into the interstitial, causing edema. And also hypoalbuminemia also stimulate the lipoprotein synthesis, which reduce the lipoprotein metabolism and causing hyperlipidemia.
Bukan metabolism lah, production.
Oh, okay.
Okay lah, not bad. Not really a bit more than your other colleagues yang bagi sebelum ni, but not enough. So basically, the problem, first you need to know the diagnosis. How do we diagnose nephrotic syndrome? Macam mana kita diagnose nephrotic syndrome? Aiman?
We look for proteinuria.
Okay. How much?
Heavy proteinuria.
How much?
More than 4 milligram per day. More than 4 milligram per hour. And we look for
4 milligram apa?
4 milligram meter square.
Per meter square per hour. Kita tahulah. Atau apa lagi? You boleh guna satu per hour. Kalau per day berapa?
Kalau per day,
berapa gram?
more than 100 milligram meter square per day.
Okay. Ataupun satu lagi yang boleh guna?
Satu lagi.
Early morning urine starts with P. Tengah membaca somewhere tu. Cepat. Tak nampak. Starts with P. Early morning urine protein creatinine index. Early morning urine PCI, urine protein creatinine index. Value dia 200. So you need, okay, so these are proteinuria, massive proteinuria. Lepas tu nombor 2 apa? How do we diagnose nephrotic syndrome?
Hypoalbuminemia.
Of berapa value dia? 25.
Less than 25.
Less than 25.
Deciliter.
Lagi?
Then clinical evidence of edema.
Generalized edema. Okay, lagi?
We check for hyperlipidemia.
Hyperlipidemia. Okay, yes, good. Okay, so you know how do we diagnose nephrotic syndrome? Okay, so the problem is there's inflammatory process happening over the glomerular basement membrane. Dekat GBM tu dia ada podocyte and its food processors. So podocyte tu dia pegang, podocyte dengan food processors dia, podocyte tu pun dah, podo tu kaki kan. So podocyte is sel yang bentuk macam kaki. So podocyte dia ada food processors dia. So this podocyte and food processor ni dia macam filter. Basically at the glomerular basement membrane tu, it filters out. Large molecule tak boleh pass through masuk dalam dia, masuk dalam you punya blood daripada Bowman capsule tu, dia tak masuk dalam you punya collecting duct apa semua benda lah kan. So this is the function of the podocyte and its food processors. So bila ada inflammation, when there is inflammation, what happens is there is effacement of the podocyte food processors. So kita nak dengar perkataan tu. Kalau masuk dalam you punya KFQ ke, kita nampak effacement of the podocyte food processors tu, kita pun happy. So those are keywords. Kan, effacement of the podocyte food processors. So bila dia efface, lubang dia jadi besar, filter tu jadi lagi besar. So increase permeability. Larger molecules macam albumin, macam blood can pass through. Tu satu. Bukan setakat itu, it also changes the ionicity of the podocyte food processors. Sebab albumin is negatively charged. And the podocyte food processors pun generally it is negatively charged. So bila dia dua-dua negatively charged, it repels each other. Tapi bila ada inflammation, what happens is the podocyte food processors is now less negative. Dia tak jadi positif, dia jadi less negative. Bila dia less negative, it's easier for albumin that is negatively charged to pass through the podocyte food processors. So what happens? This results in a net proteinuria, massive proteinuria. The next thing yang saya nak dengar bila you present about this is massive proteinuria causes hypoalbuminemia. And hypoalbuminemia results in a shift results in a shift in the Starling forces. What are Starling forces? Bukan Starling law. Starling law dekat heart. Starling forces. Starling forces are, what is Starling forces? Your intravascular and extravascular. Intravascular oncotic pressure, hydrostatic pressure. These are Starling forces. So hypoalbuminemia disrupts your Starling forces, reduces the plasma oncotic pressure, and increases relatively the plasma hydrostatic pressure. So this disruption in the Starling forces results in a net shift of fluid from intravascular into the extravascular space, into the interstitium. Yang tu yang cause edema, pleural effusion, ascites, pericardial effusion, and so on and so forth. Basically, fluid shift from intravascular into the extracellular space because disruption in the Starling forces. Kan? This is what, and then apa jadi? The result in the reduction in the intravascular volume, intravascular fluid. So fluid dalam intravascular space akan jadi underfill, under volume. So this is what we call as the underfill theory ataupun the classical theory of nephrotic syndrome. Dia ada satu lagi newer theory which we call as the overfill theory. In overfill theory, there is activation of the RAS, renin angiotensin aldosterone system, and also activation of your antidiuretic hormone, and also activation of your vasopressin. So this causes apa? Aldosterone apa semua, they cause salt and water retention. So when there is salt and water retention, what happens is there ada oliguria, and the net water retention tu is more than the shift of fluid from intravascular to the extravascular space. So patient ni akan jadi overfill. So difference dia adalah patient yang classical theory, yang underfill ni, patient ni akan underfill. Maknanya apa? BP dia akan lowish, dia tachycardic. Kalau you buat echo, you akan nampak dia punya IVC dia small, dia underfill. Treatment dia akan beza. Patient-patient yang dan urine output dia akan normal. Dia akan dapat frothy urine. Dia tak ada oliguria. Tapi patient yang overfill theory ni, dia akan ada oliguria. Dia akan ada BP dia normal, heart rate dia pun normal. So treatment will differ. How you manage later on akan differ. Bila you tahu what is the pathophysiology for the patient. Faham tak? That is why bila you dapat patient nephrotic syndrome ni, you kena boleh bezakan di antara dia underfill or overfill theory, because how you manage will differ. Kan? Contohnya you nak bagi albumin, for example. Kalau dia overfill, kalau dia under overfill theory, bila you bagi albumin, what will happen? What will happen kalau you bagi albumin? Bila you bagi albumin, you increasekan plasma oncotic pressure. Bila you increase plasma oncotic pressure, you akan absorb water daripada extravascular tu akan masuk dalam intravascular space. Dia dah already overfill. Kan? So what will happen? BP akan lagi naik lah. BP akan lagi naik, boleh cause heart failure. Kan? Sebab fluid tiba-tiba jadi banyak. So this sort of patient, kalau you bagi albumin, you kena bagi furosemide sekali. Sebab dia dah already overfill. Tapi kalau dia underfill, contohnya yang overfill, underfill ni you buat x-ray. Kalau you buat x-ray, kalau yang overfill, you akan nampak cardiomegaly. Kalau yang underfill, you akan nampak heart dia shrink, mediastinum dia kecil dia. Kan? So kalau dia underfill, kalau you bagi albumin, kan, fluid daripada interstitium, daripada ascites dia semua akan masuk balik dalam intravascular. Kan? You kena bagi furosemide tak? You tak payahlah bagi, sebab kalau you bagi furosemide, dia akan lagi fluid depleted. Kan? Lagilah underfill dia, lagi stress. Kan? Boleh pergi shock dan sebagainya. So that's the thing. What I'm trying to say is, when you clerk patient, when you examine patient physically, you need to understand the pathophysiology behind the disease. Because when you understand the pathophysiology behind the disease, baru you boleh tahu macam mana you nak manage. Faham? Dapat tak? Faham tak? Faham tak? Faham tak? Faham tak? Faham tak? Nephrotic syndrome is very common for exam. Okay, next. Tadi Farah ada saja dah ke tadi? Apa tak? I belum tak. Okay, fine. Tell me, pathophysiology of AGN. Oh wait, before you go. Tadi juga Syafiqah sebut mula-mula sekali, idiopathic. Okay, what I say is macam ni. Nephrotic syndrome, you divide into two. Primary or secondary nephrotic syndrome. Primary nephrotic syndrome, 80 to 90% of nephrotic syndrome, bukan idiopathic, what we say is minimal change nephrotic syndrome. Minimal change tu maknanya if you do histology, there's nothing, it's normal. You only see the changes if you do electron microscopy. That's minimal change. So 80 to 90% is minimal change. This is what we've been talking about tadi. Kan? The other cause for primary nephrotic syndrome is FSGS, focal segmental glomerulosclerosis, ataupun messenger membranoproliferative nephrotic syndrome. So ni primary cause. Secondary nephrotic syndrome ni ada banyak. Hepatitis B, HIV, IgA nephropathy, henoxon 9 purpura can cause nephropathy, SLE, lupus nephritis, post streptococcal pun boleh cause nephrotic syndrome, kan? Any food yang boleh cause nephrotic syndrome tak? Makanan? Any food yang boleh cause nephrotic syndrome?
Yes.
Apa?
Jering.
Jering, yes. Apa dalam bahasa dia? Jengkol, jengkol dalam bahasa Indonesia ataupun dalam bahasa Dutch, jengkol. So dia panggil jengkol nephropathy. Jengkol nephropathy ni jering lah. Orang sekarang ni tak makan jering dah, kan? So jering can cause nephropathy. I've seen patient with jengkol nephropathy. Okay, so basically this is how you classify nephrotic syndrome. Okay, alright. Farah, Anis, again, pathophysiology, AGN.
For AGN, mostly it is caused by post-streptococcus infection, meaning that the patient is infected by streptococcus before. So maybe the patient presented with fever 1 week prior before the facial puffiness. And then there are group A beta hemolytic streptococcus molecular mimicry. And then it lead to antibody complex deposition in the glomerular basement membrane, and it activate inflammatory cascade, complement activation, cytokine activation, interleukin, and also TNF that will affect the glomerular filtration rate, so that protein can pass through the glomerulus because of the inflammation. I think that's all.
Boleh lah. Okay, so ada few keywords yang I think I would like to hear tadi. That's very good. Okay, so basically majority of AGN is caused by post-streptococcal infection. So post-streptococcal basically is group A beta hemolytic streptococcus such as Streptococcus pyogenes. So biasa dia akan ada prior punya infection by streptococcus, evidence by pharyngitis, tonsillitis ataupun impetigo skin infection, impetigo. Okay, so this is prior infection. And you know streptococcus ni dia ada beberapa strain. Dia ada strain yang kita panggil cardiogenic strain. Cardiogenic strain ni akan cause rheumatic carditis. Dia ada nephrogenic strain yang cause AGN. So dia tak cross reactive. Satu orang takkan dapat dua-dua sekali. Satu streptococcus infection dapat dua-dua, rheumatic and also AGN. Tak, because these are different strains of streptococcus. You dapat satu lah. You won't get both. So dia ada two different strain, nephrogenic and cardiogenic strain. So what happens is bila ada infection, our body produces antibody lawan dia. Cuma because of molecular mimicry ni, what happens in post nephrogenic group A beta streptococcus ni is there will be antibody complex deposition. Antibody complex deposition on the GBM. So it is not kuman tu yang pergi duduk, pergi serang your GBM, but it is the antibody that is deposited dekat situ because of the molecular mimicry, and this results in a cascade of problems. Inflammatory reaction, cytokine activation, semua benda tu lah. So all this causes inflammation, and this results in damage of the GBM and a reduction in the GFR. GFR reduced causes oliguria. Inflammation causes hematuria. You can have proteinuria as well. Dia jadi nephrotic syndrome, kan? And this results yang jadi GFR causes overfill. GFR causes overfill, activation of RAS as well. So there's salt and water retention. There's water retention causing hypertension, hematuria, oliguria because of reduced GFR. So this is what happens in post-rep GM. Okay, these are common questions. It can come in theory, it can come in MCQ, KFQ, whatever QQ yang ada. It can come in your man or ski. It can come in unmanned or ski pun. It commonly comes in your long case as well. And I can assure you, bila you pergi final year nanti, nephrotic syndrome always comes up for professional exam. And again, you need to know the pathophysiology because it's so easy. Okay, all right. It's already 1 hour 20 minutes. I'm not gonna go anymore. This is already too long. It's beyond my standard already of doing class around 1 hour. Any burning question before we stop? Tak ada. Faham semua? Clear. Next time bila I allow you to ask question, you can ask adequate questions to cater for all the 4 objectives. Boleh? Tadi tak complete kan? Banyak benda tak settle. Untuk yang any of the 4 objective pun tak clear lagi. So next time, next session with me, I don't know lah ada ke tak ada lagi CBL session with me. Kalau tak ada, you'll see me again masa face to face. I don't care. I expect you to, when you present case, when you do whatever, you need to cover all the 4 objectives. Okay. All right. Fine. Okay.
I want to ask. In order to cater the 4 objectives, does it depend on the shift complaint, or does it have to be based on the history of presenting illness that we ask after that?
It need to be based on everything. You need to be based on everything. Again, you without knowing the chief complaint, macam mana you nak tanya? Faham tak? There must be a chief complaint, kan? So you formulate your differential diagnosis based on the chief complaint. Lepas tu you tambah-tambah dia, betul? Satu lagi benda I need to remind you, chief complaint does not necessarily mean exactly what the reason why the mother brings the patient to the hospital. For example, I give you one example. If you have a child, if the diagnosis is febrile seizure, what is the usual chief complaint? What is the reason why mother brings to the hospital? Because of the seizure lah, kan, Sawan? Without the seizure, just ada fever saja, will the mother bring the child to the hospital? Most likely no. Kan? So many students, dia buat chief complaint macam mana? Okay, I have here a 3-year-old boy presented with seizure. Lepas tu dia pun cerita pasal seizure, lepas tu baru 3 days prior to admission, the patient has fever. Dia macam you dah dengar satu benda, lepas tu you patah balik. Dia pening, untuk kepala otak manusia ni dia pening sikit. So what I usually do is, again, the chief complaint you formulate, bukan exactly verbatim apa yang mother cakap. For example, what I would do is, I give 3-year-old Malay boy with strong family history of febrile seizure. Currently presented with fever for 3 days and seizure on day of admission. Kalau you cakap macam tu, by chief complaint je, orang dah tahu dah, okay, this is the provisional diagnosis that you are trying to show. Lepas tu you cerita lah. Again, bila you cerita according to the timeline. You bukan start at the seizure. You start from the child was well before until 3 days prior to admission. So you cerita dalam bentuk timeline. Baru otak manusia ni boleh faham. Dia tak payah susun sendiri dalam kepala dia. Faham? what parents say, what mothers say is always important, but it may not necessarily be significant. You decide what is significant. Okay, faham? Kuah. Okay, alright. So the 4:56, I need to go and fetch my son. Okay, let's end our session with Tasbih Kafarah and Salat Last. If there's any other question, you can ask me by WhatsApp or you can ask me in the next session if you have any question lah. Okay, alright. Assalamualaikum warahmatullahi.
Waalaikumsalam. Thank you, Doctor.
Thank you, Doctor.